Madam Chair.
Welcome to the Senate Finance Committee. Today is Tuesday, April 1st. We are here to hear 3 bills and have a voting session and some concurrences. I apologize for the late start, but we were just coming off the floor, and I gave my committee members 20 minutes to get here with their lunch. So the ones that are here, you're probably going to see them eating. And we are going to start today with the House Bill 1069 and Delegate Warman, Life and Health Insurance Policies and Annuity. Thank you.
Thank you so much, Chair Vital, Vice Chair Hayes, and members of the Senate Finance Committee. This is my first time here, so very happy to see you. For the record, my name is Delegate Teresa Warman. Thank you for the opportunity to present this bill. So what this bill does is plain and simple. It closes a loophole. Discretionary clauses were banned in disability insurance policies in Maryland back in 2011, thanks to Chair Peña Melnick's leadership. My bill extends the same protection to life insurance, annuity contracts, and health insurance policies. It restores fairness by ensuring if there's a dispute over a policy, the decision isn't left solely to the insurance company's interpretation. It gives the industry time to adjust, applying only to policies issued, delivered, or renewed on or after January 1st, 2026. Now, I know many of you are well-versed in insurance law, but for the record and for anyone who might be listening who might not be, discretionary clauses are provisions in insurance policies that give the company the sole authority to interpret the terms of the contract and decide whether a claim is payable. And if a policyholder challenges that decision in court, the court often defers to the company's judgment, unless there's a clear abuse of discretion. It's like giving one team the power to write the rule book and referee the game. That's not how we do contracts in Maryland, or at least it shouldn't be. The bill isn't about punishing insurers or tipping the scale the other way. It's about ensuring both parties have equal footing when there's a disagreement, and that contract disputes are resolved under the same neutral standards we apply in every other area of the law. Insurance works best when people trust the process, and trust comes from fairness, transparency, and consistency, not one-sided rules baked into the fine print. I also want to point out that we did work with the Maryland Insurance Administration, and we adopted their suggested amendments, and they're in support of the bill. I respectfully ask for a favorable report for HB 1069. Thank you again for your time and for continuing to lead on behalf of Maryland consumers.
Well, thank you, Delegate. Welcome to the Finance Committee.
Thank you.
Do we have any questions at all for this delegate on House Bill 1069? Seeing no questions, that ends the hearing. Thank you, Delegate.
Thank you.
Now we're going to have Delegate Martinez, House Bill 933, Nursing Homes Cost Report. Welcome, Delegate.
Thank you. And so, good afternoon, Chair Beidel and esteemed members of the Finance Committee. For the record, I'm Delegate Ashanti Martinez, here to testify in support of House Bill 933, which requires the Maryland Department of Health to complete a study to review cost reports and other data submitted by nursing homes participating in the Maryland Medical Assistance Program. This legislation addresses a pressing need for increased oversight in how nursing homes allocate their revenues, particularly regarding contracted nursing care services and the salaries and wages of direct care non-administrative staff. Nursing homes provide vital services to some of Maryland's most vulnerable residents, and ensuring that state funding is used appropriately is a matter of both fiscal responsibility and public health. Transparency in these expenditures will help policymakers and public understand whether Medicaid reimbursements are being used effectively to support quality patient care. House Bill 933 has garnered support from key stakeholders such as the Maryland Department of Health, Public Justice Center, the Maryland Continuing Care Residents Association, as well as 1199 SEIU. This bill is an essential measure to improve transparency and accountability in nursing home funding and operations, and for those reasons, I respectfully urge the committee to issue a favorable report on House Bill 933.
Thank you, Delegate. Do I have any questions for Delegate Martinez? I don't see any questions. Thank you very much for your testimony.
Thank you.
Thank you. And then our final bill hearing for today is House Bill 905, Delegate White Highland. Hospitals, clinical staffing committees, and plans. Do you have anyone you want to bring up on your panel?
Yes, I have two
Lorraine
witnesses
Aricott
here.
Thank you.
So good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Senate Finance Committee. For the record, I am Delegate Jennifer White Holland, presenting HB 905 for your consideration. Thank you for the opportunity to come before you today. The Senate cross-file SB 720, sponsored by Senator Augustine, was heard on March 4th in this committee, and so I will spare you the long prose, but simply give you a reminder that the Safe Staffing Act of 2025 will ensure that hospitals in Maryland create clinical staffing committees that have equal membership from management and employees, and require the committee to develop, review, evaluate, revise as appropriate these staffing plans. Similar legislation has been passed in 9 other states, and you will see in your floor system elevating the example in New York. You'll see testimony therein and how they've implemented this legislation in their state. Stemming from these conversations that we've had with a variety of stakeholders, as well as extensive discussions in the Government Operations and Health Facilities Subcommittee, several amendments were brought forward and incorporated in the bill that you see before you today. The amendment proposed by MedChi would ensure that a physician who is not a hospital employee or administrator is included in the clinical staffing committee, whether or not that the hospital is a teaching hospital. In addition, 2 amendments were brought forth that addresses the Maryland Hospital Association's concerns. The first being that the criteria for the clinical staffing plans were far too rigid, requiring a separate plan for each unit. And so in response, the bill removed this language regarding criteria for the plan and substituted on the bottom of page 3, much more general language that does not mention a separate plan for each unit. The other concern was about the public posting on each hospital's website and how it would endanger patient safety. In response, this section was removed on page 5, lines 15 through 16. These were the primary objections raised. Other arguments that were made is the fact that some hospitals are already doing this, which this bill would not uproot, and we applaud and appreciate and build on top of the shared governance model that some of our hospitals already do. And so you will also see language for reports to be provided to the Senate Finance Committee and House Health and Government Operations Committee to be received on how the Hospital Safe Staffing Committee has addressed safe hospital staffing through the plan beginning in 2029. And so as we look ahead to the ahead model, pun intended, HB 905 is a tool that will help hospitals meet performance measures for quality, health equity, and support healthcare delivery. And so this is an opportunity for our state to be a leader and to blend the use of staffing committees, staffing plans, and reporting together, which will better position our state to care for those who care so much for others. Overall, this is a hybrid approach that will yield staffing plans that are worker-driven and flexible. This bill will ensure that the voices and perspectives of our healthcare workforce are at the decision-making table, make improvements to workplace safety, address staff turnover, and improve how we deliver care. I respectfully request a favorable report to this bill as amended. Thank you for your consideration, and now I'll turn it over to my panel.
Good afternoon, Madam Chair. Am I on? No. Yes. Good afternoon, Madam Chair and members of the Senate Finance Committee. My name is Tammy Bresnahan. I am the Senior Director of Advocacy for ARP Maryland. I'm here in my last week in this role on behalf of ARP, who represents over 850,000 members in strong support of House Bill 905. We thank Delegate White-Holland for her leadership on House Bill 905, and we thank this committee for all they've done to protect patients. As you know, Maryland has one of the worst emergency room wait times in the country. For the past 9 years is 46 in staff bed, and 1 in 4 nursing positions are vacant. Short staffing is problematic and traumatic for workers, but most specifically for patients. Older patients frequently require more intensive and coordinated care due to chronic conditions. A well-staffed, well-trained, and well-supported clinical workforce is vital to providing the safe, responsive care that older adults deserve. Clinical staffing committees that include an employee, patient, and management voices can help ensure that staffing plans are realistic, adaptive, and patient-centered. This is important because, for example, when wound care technician is in the hospital or understaffed, patients get delayed care, which can lead to sepsis and other critical diseases. With short staffing, it's much harder to monitor and take preventive actions before patients experience life-threatening emergencies. And I know this well, as my own mother spent a great deal of time in the emergency room as an 86-year-old. If one department is short, it creates a domino effect. The legislation is collaborative and flexible, and as Delegate White Holland suggested, all the amendments have been thoughtfully proposed and worked out. By passing House Bill 905, Maryland will join 9 other states in management staffing committees. We urge you and the committee to call this bill for a vote and to continue being the healthcare champions we know that you are. We thank you, and I thank you for 25 years down here.
Good afternoon. My name is Lorraine Aricot with the Patient Worker Collaborative, a coalition representing over 1.2 million Marylanders who are affected by the hospital short staffing crisis and here in favor of HB 905. I want to acknowledge and appreciate the state efforts for healthcare recruitment and how valuable it has been, but it alone is not enough to retain workers, and that's what this bill aims to do. If we don't take action, data shows that by 2027, almost 900,000, or almost 1/5 of all RNs across the country, intend to leave the workforce. And this is more pronounced in new nurses joining the field who feel conditions are too risky to work understaffed, while our seasoned nurses are not sticking around to be mentors because they are burned out and choosing to leave bedside care or the field entirely because they feel they're ethically not providing quality care that patients deserve. Short staffing is dangerous for both workers and patients. When we rely simply on unit-by-unit staffing approaches, as is the current practice in some hospitals, there is no way of tracking effectiveness of staffing strategies and how this impacts the entire hospital. For example, environmental service workers in the department work throughout the hospital, and one hospital's attempted solution was to change workers' shifts so that there would be staggering times for clocking in and clocking out, and requiring workers to come every other weekend. However, that plan backfired. Workers struggled with childcare and transportation due to those scheduled changes, and ultimately more workers quit and more workers called out, which increased the burden on their lives. This had a detrimental impact on the entire hospital, who rely on these workers for clean beds and serving patients. Maryland hospitals agree that joint labor management committees are best practice, and they have worked successfully a number of times in the past. So why are they opposed to working together to address patient safety through staffing support strategies when our amendments have actually addressed all of their concerns? The Safe Staffing Act not only gives workers and patients a voice, it gives hospitals the benefit of implementing a staffing plan that will actually work. So we urge you, Chair Beidel, members of this committee, to give patient and worker voices a chance at being part of the solution. Thank you.
Thank you. Senator Lamb.
Thank you, Madam Chair. I know, Delegate White Holland, you went through a bunch of changes there, and these changes seem to address some of the issues that the Maryland Hospital Association has brought up. Was there anything else that had been identified that had not been addressed, or how can you just clarify how you collaborated with MHA on addressing these through the changes that you? Some of it was narrowed. You took some language out to address some of those concerns, right?
Yes, and thank you, Senator, for your question. I would say that we had, as I said, extensive conversations, and we wanted to at least offer, and demonstrate how we were addressing some of those concerns. They still remain opposed to the bill, even in its amended form. But despite that, we still were making attempts to address some of the concerns that were raised, and saw that these amendments were an appropriate way to move forward in that regard. So again, there are still concerns and arguments that they make, but again, we did all in which that we could do to really put forth and collaboratively, and even in our subcommittee, to really make sure that we could iron out some of those issues that were brought forth in some of our stakeholder discussions, but still remain at an impasse.
Okay, thank you.
Thank you. Who's first? Senator Kramer?
Thank you, Madam Chair. And Tammy, sorry to hear that you're going to be parting ways with AARP. I hope whatever the future holds, it'll be a good thing. But thank you for all your involvement and the work that you've done on seniors issues. It's all been very important, and certainly you'll be missed in that role. Quick question. Many of our seniors in nursing homes come directly from hospital stays, and yet the state has been completely failing these vulnerable residents in nursing homes because they can't even get in there and put eyes on these facilities to do inspections. And I know that many of these residents are concerned about going back into the hospital because of the poor care they're getting, very largely due to the Department of Health's failures. In your capacity with AARP, have you had interaction with some of these, folks, and can you share what kind of feedback you've had from these patients?
Well, I have personal and professional experience. My own mother spent a great deal of time towards the end of her life in and out of the hospital, in Luminous Care and in Baltimore, Washington. And by the time she left Luminous, at the time it was just Anne Arundel Medical Center, she was transported to a nursing home where she contracted an infection, a really death-defying infection called C. diff. And, after a couple back and forth, she had to go back to the hospital. So when the hospital is receiving and/or the nursing home is receiving, they're the sickest, most individuals. They have high chronic conditions. And it was hard because when she would go back to the hospital, they didn't always admit her. They kept her in observation, or they kept her in the hallway, or they kept her somewhere else. So
Because of short staffing.
Yes.
No, please continue. I just wanted
But
to
that
clarify
was my
that.
experience, and that's the experience that I've heard from other of our members, is that when they go to the hospital. Now, probably you all don't know this, but a couple of weeks ago, I had a serious fall in Pocomoke, and I was rushed to the hospital because I had a head injury and I was bleeding profusely from my head. I ended up getting four staples in my head. I know, do I have a memory anymore? And I was taken to Tidal Health by ambulance, and I was there. The emergency room, they were busy. But I thought, I'll be sitting here. They wrapped my head up. I'll be sitting here for hours. I got there at 9:35 at Tidal Health. I had 5 X-rays, staples, a prescription, and I was released by 11:20. Just so that's my, as a 65-year-old, right, and a bleeding head. So I've seen both sides of it, and I've experienced both sides of it personally, professionally, and so it does seem to be an issue, but not everywhere.
Thank you. Thank you, Madam Chair.
Thank you, Senator. Senator Reed?
Thank you. And I on this bill, and I don't really know who to address the question to, but we all really want to deal with the staffing at the hospitals. I think we all agree that it's a challenge. Can you kind of help me understand, and maybe it's for the sponsor or someone else on the panel? I mean, I know the first answer to the question I'm asking is going to be, well, this will help make people want to work there because they'll feel like they're more invested in how their day is going to go, how their work schedules will go. But the problem we've got with a lot of our hospitals is they just don't have enough people to hire right now. It's not so much that they're certainly not keeping people on the shelf and not letting them work. And so, I mean, the challenge with a lot of the staffing is that with the kind of a rigid staffing structure and putting it in law, the concern is that the problem right now is we don't have the manpower or the woman power, the man and woman power to meet the goals. So I don't know if you can comment on that and how this won't just be another thing they've got to kind of meet as a mandate as opposed to really helping to address the situation.
Yeah, thank you so much, Senator, for that question. And something that is really important to remember is that we don't have a healthcare workforce shortage because there's a lack of members that want to work. We have a healthcare workforce shortage because there's a lack of workers that are willing to put themselves in conditions where they can't provide that care that patients deserve and have the support they need to do their job well. And that's what we mean by retention efforts, right? We have done an amazing job with bolstering our education pipeline, right? And those efforts can't be minimized. We actually have more newer nurses coming into the hospitals, but they're not feeling supported, right? A lot of those seasoned nurses are not staying in their fields to mentor those newer nurses. And they're working in conditions where they can't meet all of those patients' needs. And so what the staffing committees do is that they're extremely flexible, right? They're not putting into law anything that mandates the hospital to change their structures. It makes it so that each hospital has a conversation where workers are at the table, patient advocates are at the table, and they're looking at, hey, what does our hospital in our region, right? It's flexible to each hospital. What are patient acuity? What is the population needs? What are workforce skill sets in our department or in our hospital? And how do we make sure that workers feel supported? How can we make sure there's more mentorship and that we're actually meeting those patient needs? So I want to make sure that you're left with remembering that staffing committees and these staffing plans are extremely flexible and don't plan on kind of making anything into law.
I appreciate the clarification on that. I'm looking through the bill. I wonder if you could give me an example of somebody saying, I can't meet my patient's need, and that's why I'm not going my patient's needs. What are some examples of that kind of thing? Because I also think some of this is about needing to raise wages, which, look, there's competition now with private nursing and with the traveling nurses, and that's a very real factor. Some of that's been a good thing. Probably some of it maybe isn't all good, but I know this is not just about wages. So can you give me some, like a couple of specific examples of not being up, somebody saying, I can't meet my patient's need because of X?
Yeah, I think so many of our healthcare workers want to provide holistic, compassionate care, where they're there not only for tasks that are needed and required, but they want to provide that emotional support that patients need. But they're unable to do that completely, right?
Because they're overworked, overbooked?
They're overworked, they're burnt out, they barely have time to do those necessary things they need. So when a mother with a NICU baby is needing extra support, that nurse might not be able to provide that extra support. And sometimes that extra support is exactly what is needed for that patient. So that's an example, but there's multiple examples. There are patients who's have their light for needing support for even just a glass of water for over, hours at a time. And if it's just a glass of water, it's one thing, but what if it was something more serious? And that's only because workers are understaffed. They can't meet all of those call lights that are being turned on and waiting for support. And there are examples.
So, and I'm not to cut you off, but so if the problem is that if the staffing is the problem, you're talking about the pipeline, all the new nurses we have coming, but it sounds like they're not taking those jobs. If they took those jobs, there'd be better quality there'd be more people to work, right? Or, I mean, I'm trying to get at what we're really getting at here. Yeah.
It's about retention, right? They're coming into these jobs, but
they're not staying.
how are we supporting them? And they're not staying, right? And it's on both ends, new workers and also seasoned workers. And this is just a way to make sure that we are collaborating together to meet those challenges. And the people who are closest to the problems are also closest to those solutions. And that's what this bill does.
So hospitals currently, in your all view, are not doing this with workers already in a maybe more of an ad hoc way?
So some are, and some take a unit-by-unit approach, right? And what that means is they're talking about what is the schedule for next week. It's very urgent. It's talking about how do we make sure these spots are filled. But what the staffing committees do is it zooms out and says, hey, what is happening on these unit-by-unit? What are patterns that are happening, and looking at overall strategies and approaches that can retain workers, and not just these numbers and metrics, which actually show to be not as effective, right? We're not thinking about these workers as people, but we're just thinking of numbers and metrics, and this aims to kind of take that back and allow workers to have their voice. And workers are going to hear from managers who are sitting in these committees, we're not able to hire more staff. They might be saying that, which they probably will. And so workers and management are coming together and saying, okay, so then what is feasible for safe patient care amidst these challenges that hospitals have? And so I think that's the reality, and this committee is able to work through that.
Okay. Thank you very much. Thank you, Madam Chair.
Thank you. Senator Jackson?
Thank you, Madam Chair. This question is for Lorraine. You mentioned in your testimony that workers are experiencing dangerous conditions due to staffing challenges. Can you share some examples of unsafe conditions and how this bill would change that?
Thank you, Senator, for that question. 1199 SEIU has over 5,000 members in Maryland hospitals that are working in a lot of understaffed conditions. And we know from their experience and their words that short staffing is creating a both emotional and physical toll on them. One of our members works in a behavioral health unit in a hospital and is completely understaffed, where you're supposed to be giving patients 15-minute wellness checks. And this department was not able to do that because of short staffing, and tragically, a patient committed suicide in that department. In another hospital, Capital Region, we had a member who was the only worker on that floor and was brutally beaten by a patient, and there was no other coworker to support that worker that got beaten. She was so injured and so bloodied that another patient had to come out and help her. And these are the types of things that shouldn't be the case. We should have the staff there to support that worker. And this is why we're taking a whole care team approach, because it's not just about nurses, it's about technicians, it's about everyone that is moving through that department. It's about the environmental service worker who's cleaning the beds, all of that. And it's traumatic for both workers and patients. And the work of the staffing committees allow workers to voice those concerns, especially considering what is unsafe for them, but also unsafe for patients. And they're trying to figure out what are the skill sets available in their department, what are the ways we can support new members with mentorship. All of these strategies are discussed so that we actually support the workers and make sure that safe staffing is available so that patients also receive the best care. And so they look at a number of different factors that even fluctuate based on shift, right? So a night nurse might have different challenges versus someone who's on day shift. And our nurse in New York actually gave a really fantastic testimony of their New York staffing committee was passed a couple years ago, and they have a 2-year report on the successes of that staffing committee. She has shown that she has felt more empowered in her role now. Many of her other colleagues feel the same way. And they have really been able to make these small changes that make a big difference.
Thank you. Thank you, Madam Chair.
Thank you, Senator. Lorraine, SEIU, other than state hospitals, how many hospitals would SEIU have a presence in?
We actually don't have state hospitals, and
Okay, so you're not in Perkins or any of that?
we say it one
You're
more
not
time.
like in Perkins or any of the state?
No, we're not.
Okay. So how many hospitals do you have members in?
We have a handful of hospitals.
Do you know how many? You must know how many hospitals you actually have members that work in.
I don't have the exact number of hospitals, but it is not, the wide array of.
It's just a few.
It's
So
just a few.
Do you feel like the problems are in the hospitals that you're firsthand knowledge of? Or do you feel like this is a problem in all hospitals? Because we're only hearing from the hospitals that seem to have SEIU members, and I don't understand if they're the only hospitals with a problem.
I don't think so. Our patient worker collaborative has healthcare workers from across the state. So this is not just a union hospital issue. It is really across the hospitals in Maryland. And many of our testimonies and many of our letters and emails to this committee kind of shows that it's really happening across the board. And not every hospital is the same, right? And so we really have to make sure that we have a way to track that data that's coming in and informing in ongoing work that's happening, because staffing data is essential, right? We can't forget that. Even when we created a joint labor committee for workplace safety, right? We thought that was going to address it, right? But if we look at workplace safety in the angle of how do we make sure patients know that they can't hurt a worker, we're only looking at it in that angle. But what about how are staffing and staffing strategies supporting and preventing workplace violence happening in the first place? So that's why the staffing data is essential for just meeting a lot of the hospital throughput challenges that you are working on, many state leaders are working on.
Thank you. Do I have any other questions for this panel? Seeing no questions, and again, congratulations, Tammy. Thank you for being here, always for your testimony. Thank you. We actually have 2 unfavorables, but I think one couldn't stay. So Andrew Nicholas from the Hospital Association. Andrew, your other person had to leave. I'm really sorry. No one's sorrier than we are that we were on the floor for 4 hours.
I understand. Not a problem. I'm sorry that you're just stuck with me, so my apologies for that. All right. So good afternoon, Madam Chair, Mr. Vice Chairman, members of the committee. For the record, my name is Andrew Nicholas, representing the Maryland Hospital Association here in continued respectful opposition to House Bill 905. So first, we appreciate the efforts taken in the House to address some of the concerns raised by hospitals. However, the fundamental concerns with this bill do remain unchanged. The bill, even as amended, requires the formation of hospital-wide clinical staffing committees that will develop hospital-wide clinical staffing plans that will then dictate how many personnel need to be assigned at each unit within the hospital. As we've testified to previously, clinical staffing plans are reviewed regularly and repeatedly throughout the day, throughout the day, every day. And that's why they must be done at the unit-by-unit level where they have the utmost flexibility and adaptability. So as you can see in our written testimony, hospitals are already complying with regulatory and accreditation standards from CMS and the Joint Commission to ensure adequate staffing. Furthermore, many hospitals in Maryland are being recognized for nursing excellence through nationally recognized programs, including the Magnet designation and the Pathway to Excellence program. And nationally, less than 10% of hospitals receive these designations. In Maryland, nearly 40% of our acute care hospitals have them. And so Maryland hospitals are also embracing shared governance and engaging directly with our frontline staff in making staffing decisions. And you can see in our written testimony a variety of techniques that is taking place in collaborative governance structures, shared leadership councils, and many others. So MHA has worked to gather information on current practices in hospitals during this session. However, we do not have yet a comprehensive look at all the ways hospitals are meeting the current requirements for hospital staffing and a full picture of the various ways that hospitals are leaning into and implementing shared governance. I think getting that picture will provide some valuable insight on this issue, and that is something that MHA and the hospital industry is committed to doing. So I want to be clear, no one is saying that there aren't workforce challenges. To your point, Senator Reedy, there is a national workforce shortage stemming from a generational transition of baby boomers retiring and younger workers not going into this line of work. And it's not just hospitals, police, fire, EMS, teachers, all dealing with national workforce shortages. However, hospitals have leaned into this. They've not hidden the fact. They were the first to wave the flag about this shortage, and House Bill 905 does not address those root causes of the workforce shortage and simply fails to reflect the complexities within hospital staffing. And so for that, we urge an unfavorable report. Apologies for going over, Madam Chair.
Thank you, Andrew. Senator Washington?
Thank you, Madam Chair. Just wanted to go off the last few questions that the chair asked SEIU. Do you know how many hospitals SEIU is only in?
I believe they are in 6 and represent nursing in 2.
Got it. About how many employees? You know? No.
I don't know. I believe their number's probably accurate. I'm not sure.
Are there staffing issues only at those hospitals that they're located at, or are they at all hospitals?
All hospitals in the country.
In the state, too, right?
In the state, yes.
Yeah, okay, cool. And so you mentioned part of the bill, it's cumbersome, but can you just tell us what in the bill can we change to make it more amenable to MHA?
Sure. So I think, really what I appreciate that question, Senator. I think to fully answer it, we would benefit from taking the time to look at what's going on currently. We do not have a comprehensive look at that, and we know, as was testified to and as you can see, hospitals are meeting extensive requirements already as far as ensuring adequate staffing. So what are the techniques being used to meet those requirements, as well as various hospitals, the way they're implementing and currently doing shared governance. And now that looks different and should look different because all hospitals are situated differently, from rural to academic and everything in between. But I think getting a picture of what that looks like can inform kind of decisions in how we approach these issues on a statewide basis. And so right now, I just feel like we don't have enough information to even do something even close to sort of a blanket rule that applies to all hospitals. Does that make sense?
Yeah, so you need a baseline of activities that are occurring within the hospitals that you all represent?
Yeah, yes, sir. I think that's accurate. I think that'd be good to have to understand.
And that hasn't happened at all?
We have a sense of some. We've been working to gather it, but I'll admit it is not comprehensive. And so we would like to take that time. And I think we could even engage other stakeholders, right, and seek other inputs on something like that. Okay. But that's something I think, or no, not I think, I know that MHA wants to do and is committed to doing going forward.
Thank you.
Thank you, Senator. And Senator Ellis?
Thank you, Madam Chair. Thank you for your testimony.
Yes, sir.
Question, so how are hospitals have to be accredited, right?
Yes, sir.
Leverages the accreditation requirement to meet clinical staffing needs.
So the Joint Commission does set requirements regarding staffing. They're spoken to more specifically in our written testimony. And all hospitals are evaluated by that. Joint Commission does routine inspections as well as surprise inspections. And I don't know if that was the reason that my other witness had to leave or not, but they just show up and you have to show that you're meeting their requirements. And so that's how they enforce those.
I'm sorry, go ahead.
No, good.
Now, how do the hospitals do, especially with the surprise?
They do very well because they know that it can come, right? When you know you have that sort of threat over your head at any time, somebody could drop by and they do it. Yeah. You have to stay on the ball and make sure you're compliant.
So with the staff and shortages, like we just heard, we have a 25% with nurses average across the state in Southern Maryland, Charles County, which I represent. It's more.
It is more.
So
yes.
how? I mean, and they always pass, you're saying?
Well, if there's anything that's not, typically what would happen is you have to do a corrective action plan as to how you're gonna fix it.
Yeah.
And so that certainly can happen. I can't say it's always. But
sometimes.
Sure, of course.
Yeah. Okay.
Yeah.
Great. Thank you.
Absolutely.
Yeah. Thank you, Madam Chair.
Thank you, Senator. Do I have any other questions for Andrew? Thank you. That ends the hearing on House Bill 905. It ends our hearings for today. We're going to give our manager a few minutes to get switched over to our voting session. Thank you.